Good morning. Thank you so much for the invitation to speak today. As I said, it's an honor and a real challenge to follow Amaranta, so I promise I will not be as inspirational. I'm an epidemiologist. We're not known for that, but I'll try to have comedic interludes at least to keep you all awake. So I'm going to be speaking, I've been asked to speak about the epidemiology of HIV among trans populations globally. I will begin by noting that I unfortunately have no conflicts to disclose. I'm open to them. And I apologize that my titles went a little bit wonky in the transition, but I think you can follow along. So what I will do today is I'll first speak a little bit about the burden of HIV among trans populations globally. I then also will take a few minutes to complicate what I've just said a little bit and encourage us to dig a little bit deeper and think about heterogeneity within trans populations. And then I'll talk about prevention and treatment cascade outcomes in trans populations. So I'm sure most or all of you have seen this meta-analysis from Stefan Brahl and colleagues published in 2013. They found pooled seroprevalence of 19% among transgender women in 15 high and middle income countries. And you can see here there are many parts of the world for which at the time there were no data available. Thanks to Tonya Petit for this figure. This is from that meta-analysis and shows you the 15 countries that were included, comparing HIV prevalence among all adults in blue to prevalence among transgender women in red. And you can see, of course, the huge disparity here. They estimated that trans women were 49 times as likely to be living with HIV as compared to the reproductive age population in each country. Later, a few years ago, led again by Tonya Petit, we published an article that updated this, so looking at data that were published between 2012 and 2015. What I'll just highlight here are a few points of incidence data that became available for this review. So for example, in Lima, a study estimated annual HIV incidence of 2.3 per 100. Another study in New York City with, again, high HIV incidence of 2.9 per 100 person years. And then in Spain, 1.2 per 100 person years. So we're seeing really across settings, very high levels both of prevalence and of incidence among trans women. Not news to most of you, I'm sure. Just want to highlight some new data that have become available just in the last few years since both of those reviews were published from really a wide range of settings, including settings in which there were no data available previously. So for example, studies from Beirut and Tehran, both showing prevalence much, much higher than the general population in the context of low-level epidemics, as well as data from a large national study in Cambodia, for example. So it was a national biobehavioral survey with almost 1,400 trans women. Population estimates from Rio de Janeiro, Brazil. And then most recently a study from coastal Kenya finding really alarming HIV incidence of almost 21 per 100 person years. Really small sample, but obviously really alarming to see. In addition, and in that first slide I showed you, oh, sorry, I'm going backwards instead of forwards. I don't know how to use a thing apparently. There we go. I showed you this map with the entire continent of Africa in white with no data. And thankfully, due to work led by people like Stefan Brahl and Tonya Petit and others who were here, we now do have data from a number of settings in sub-Saharan Africa. This is from a paper that Dr. Petit led in PLOS Medicine last year, where data were collected from surveys of men who have sex with men that also included transgender women in 8 different African countries. And they found first that overall, trans women were more likely to be living with HIV, with prevalence of 25% versus 14% among men who have sex with men, and that in 4 countries, trans women had significantly higher odds of living with HIV, including in countries that already have an incredibly high HIV burden, such as Lesotho listed there. Also important to note that while they were able to do this because, as Amaranta spoke to so eloquently, historically, transgender women and cisgender men, or non-trans men who have sex with men, have been lumped together in HIV research. And by simply adding a question to these supposedly MSM studies about how people actually identified their gender, the team was able to find that indeed there were high numbers of trans women in these studies, and that they had a differential HIV burden. It's also really important that we take the next step and actually have studies that are trans-specific, that are able to ask people about experiences specifically related to their history and experience as trans people. And thankfully, there is a study in South Africa that's now underway. That's a biobehavioral study focused only on trans women. And I imagine both Tonya Petit and Leanne Vandermeer, who's here, can tell you more about that. I've spoken only about transgender women so far. I'm going to speak very briefly about transmasculine people, not because it's not important, but because we have very few data. There was a review published in 2016 that synthesized data from studies of sexual behavior and HIV and STI risk among transmasculine people. They found really a handful of studies that had data on laboratory confirmed HIV status, which ranged from 0 to 4%. I'd caution that 4% was a single case, a lot of really small samples. And then self-reported HIV status ranging from 0 to 10%. Again, often quite small samples, mostly in Canada and the US. I'd also just caution that there's a bit of a denominator issue here in that many of these studies are of all transmasculine people, but we wouldn't look at a study of all men in Mexico and from that try to extrapolate the HIV prevalence of men who have sex with men. We obviously need to be thinking about the subgroup of trans men who are sexually active with cisgender men. Some new data we have also from the US that for the first time actually provide a meta-analytic estimate of HIV prevalence among transgender men. So on the right side of this slide, you can see they pooling data from studies in the US from 2006 to 2017 found 2.9% laboratory confirmed HIV prevalence among trans men and 14% among trans women. Notably, that's actually considerably lower than an earlier meta-analytic estimate from 2008. Many of you may have seen the Herbst et al. Study that estimated 27% HIV prevalence. This is probably due to the fact that in the intervening decade and a bit, there are many more population-based or more heterogeneous samples of trans people available. So I think partly it's probably a reduction in sampling bias more than anything else, but we can happy to debate that later. So I'm going to dig a bit deeper now and talk a little bit about complicating some of what I just told you. So first, I'd like to draw on this concept from my colleague Amaya Perez-Brumer of reflexive epidemiology. And what she means by that is active engagement in the complexity of categorization. So many of us who work in HIV, when we talk about trans women and HIV, we're of course actually talking about trans women who are sexually active having sex with cisgender men. And I think it's important to actually be specific about that because it's actually quite a heterosexist assumption that those two groups are equivalent, particularly in settings that I work in. So in Canada and the US primarily, we actually find that a really high proportion of trans women are not having sex with cisgender men. So these are data from a province-wide respondent-driven sampling study that we conducted in Canada, and we found that half of transgender women reported no sexual partners in the past year, and just above 20% reported cisgender male sexual partners. So I think it's important to keep that in mind as we think about HIV and trans women and getting more specific about who we're talking about. I also, as I mentioned, I do think there are issues around sampling bias here. So in the US meta-analysis I just showed you, self-reported HIV prevalence was estimated at 21%. These are data from the US Transgender Survey. It's the largest survey of trans people ever conducted, over 27,000 participants, and this was collected in 2015, and they found that overall, 1.4% of trans women reported living with HIV. Where we do see comparable estimates to the meta-analytic data I just showed you is among Black trans women, where 1 in 5 self-reported being HIV positive. And of course, that's only self-report, and as I'll show you later, there are data suggesting really high degrees of undiagnosed HIV among Black trans women in the US. And on that note, these are also data on new HIV diagnoses among trans people in the US, both transgender men on the left, who represented about 15% of new diagnoses, and trans women on the right. And you can see in blue that over half of new diagnoses were among African Americans, a minority among white individuals, the next largest being among Hispanic or Latinx individuals. So again, in terms of digging deeper, when we're talking about HIV among trans people in many settings, we're talking first about trans people who have sex with men, we're talking about Black and Latinx and Indigenous trans people. And I'm really not going to dwell, it's very strange for me to give a talk about epidemiology and not really talk about why we're seeing what we're seeing. I'm a social epidemiologist, but I also have the luxury of speaking before a whole number of people who are going to spend the entire day unpacking both the multi-level drivers of HIV among trans people and multi-level interventions to reduce HIV transmission and to improve HIV treatment outcomes. So I just want to very briefly point out that the reason why we're seeing both disparities between cisgender and transgender people and disparities, huge disparities within trans communities is because of differential vulnerability at multiple levels, from biological through public policy. And I think Amarant did a great job already of talking about public policy and the way that legal gender recognition can impede or promote involvement in the labor market, social participation, access to health services. Also need to be thinking about criminalization of sex work and of HIV. Thinking about the community level, about stigma, including in healthcare settings. And of course, we'll talk today about ways to alleviate stigma in healthcare contexts. Also need to be thinking not just about sex work. Purposely, sex work is not at the individual level in this framing, because exchanging sex for money on its own does not pose HIV risk. It's about the conditions in which people work, their ability to negotiate safer sex practices, condom use prep, or to not. That's what can put people at risk. Thinking also about social and sexual networks, so for example, sexual network density and how that can increase people's vulnerability. At the interpersonal level, I know Jay Savelius later today will speak about gender affirmation, both in terms of unmet need for gender affirmation as a contributor to vulnerability, but also about the potential to use gender affirming care to engage people in HIV prevention and treatment. And then I won't even talk about the individual and biological because I think we get enough of that. So with my time remaining, I'm going to speak about the treatment and prevention cascades. And before I do so, I'm going to do this briefly, so I want to draw your attention to a really great review article just published in Social Science and Medicine by Fontanari and colleagues that reviews global data on HIV prevention and treatment cascades among trans people. This map is probably hard to see from there because it's so white that it's actually like bleached out. All this is to say that in dark blue, unfortunately, half of the studies reporting on these outcomes among trans people were from the US. So with apologies, my next few slides are US heavy. First, in terms of testing, I'll just show one data point here. I think it's obvious to many of us that too many trans people who are at risk of HIV are not accessing testing. And people, I think, will talk later about how we can improve that. I will just say that these are data from the Behavioral Risk Factor Surveillance System in the US. So these are nationally representative data. And I think that's important because if we go to an HIV prevention program and ask people if they've been tested for HIV, the person who tested them for HIV might have been the person who recruited them into the study, so probably not the best way to get at that. So these are nationally representative data showing that trans men and women were much less likely to have been tested either over their lifetimes or over the past year, as compared to cisgender gay and bisexual men. And in fact, they were pretty much identically likely to have been tested as compared to cisgender heterosexuals. Obviously not good enough. Thinking about PrEP, here I'm going to show you some hot off the presses data, because again, willingness to use PrEP in 2012, not so informative in 2019. The ground is really shifting beneath us. These are data, again, from Tanya Potit, just came out in JAIDS, looking at the PrEP engagement cascade among Black and Latina trans women in 2 US cities. And I think what's interesting here is that actually in this study, awareness of PrEP was really high. So 87% of people said they were aware of PrEP. Among those who were aware, knowing where to get PrEP was also pretty high, 80%. And the real drop-off is in actually using PrEP. Another study, one of the really few data points on PrEP among transmasculine individuals, is a new study from Golub and colleagues and JAIDS as well. And they conducted a national survey online of transmasculine individuals in the US. And this was not a sample that was limited to people who were gay or bisexual or had sex with men. And yet they found that a fully 1/4 were PrEP eligible according to CDC guidelines, and only 3% had been prescribed. That breaks down to only 10% of those who were PrEP eligible. And the cascade they've constructed here just illustrates that most people were accessing health care. 2/3 had had an HIV test in the past year, but only 1/3 had had their physician provide them information about PrEP. And I think that's part of the issue that Amaranta spoke about transmasculine invisibility in terms of HIV, and it not necessarily being on the radar of providers of care to provide information about PrEP to transmasculine patients. I'm going to move on now and talk for a few minutes about treatment cascades. These are figures from 2 very different settings, so one from Rio de Janeiro, Brazil, the other from San Francisco. The cascades look really different across the 2 settings, but when we get to the end, we see that only about 40 to 44% are achieving virological suppression. So we see, for example, in this Brazilian example, kind of steady drop-off all along the way. In San Francisco, we see 95% having been previously diagnosed, but then real problems starting to emerge with prompt linkage to care. And the bottom line is that in these 2 very different settings with different levels of access, we still see real lagging behind in terms of viral suppression. This is the data that I alluded to earlier from Black trans women in the US. This is, again, just recently published in JAIDS. And this was a national study of Black trans women across a number of cities. I think the data were, right here, the data were collected from 2014 to 2017, so quite recently. And you can see when we get to the end here that only 1/4 of Black trans women living with HIV in this study were virally suppressed. And it's very obvious that the problem here is diagnosis. Only 41% of those who tested HIV positive had been diagnosed previously. One point I just want to briefly make, these are data that are being presented in a poster here at the conference, is that it's also really important that we actually collect data in different settings and not simply extrapolate from one to another. So this is a small sample from a survey, again, of both cisgender men who have sex with men and trans women in Kigali, Rwanda. But in this case, actually, both 10% of both trans women and MSM were living with HIV, and their outcomes along the cascade didn't vary that much. And so all that is to say is that we actually need to be collecting data in all of our regions and countries and not extrapolating from a small number of settings. The other point I want to make is that I showed you some real doom and gloom in terms of what the data look like, but none of this is inevitable. And there are also data suggesting that when trans women are engaged in care, that outcomes can look much better. So just as one example, there are data here from 2 clinical cohorts. So by definition, these are trans women who are engaged in HIV care. But in both cases, trans women fared similarly to cisgender people in terms of viral suppression. Another way of looking at this, these are some data from New York showing changes over time in viral suppression amongst cisgender men at the top line, cisgender women in the middle, and trans persons at the bottom. Obviously, everyone's viral suppression is increasing, but you can see that when viral suppression started to increase for cisgender people, the gap between cis and trans people actually widened. And in recent years, so this is 2016, there's still a gap, but it's narrowing. So all this is to say, it is definitely, there is a way to improve outcomes among trans people. Another example of that, these are data from HRSA. This is the Ryan White HIV/AIDS program in the US. It's estimated that 60% of people living with HIV in the US are virally suppressed. Among the Ryan White population, it's 85%. Among trans clients in Ryan White, and there's about 6,000 of them, they're at 81% viral suppression. So still a ways to go, but a smaller gap than we see in other settings. And you can also see here some of the real structural drivers of poorer outcomes among trans people. So we have much lower levels of viral suppression among trans people who are unstably housed or in temporary housing. And I also should have mentioned that in these data I showed you from Black trans women in the US, what was associated with both undiagnosed HIV and unsuppressed viral load, incarceration, homelessness, unstable housing. In these examples from Brazil and San Francisco, unstable housing, again, associated with unsuppressed viral load in both settings. So in summary, as we've seen, and I think you already knew, trans populations face extremely high HIV burden across settings, and also importantly, we have a growing evidence base across epidemic contexts, so including in generalized epidemic settings in sub-Saharan Africa, in low-level epidemic contexts in the Middle East or North Africa. And we also see, and I always really try to bring this point home, is that risk is very unevenly distributed within trans communities. Our cascade data remains sparse outside the US, but I think clear indication that we have work to do. And again, to highlight the importance of addressing structural barriers to prevent HIV acquisition and improve cascade outcomes. So I'll leave it there, and I really look forward to all the rest of the speakers who will do a much better job than me of explaining why we're in this situation and how we get out of it. Thank you.